Good morning. Thank you, Nancy. It gives me great pleasure this morning to introduce Dr. Bonnie Vesey, who will start our day with her presentation, A New Landscape for Public Health and Public Safety. Dr. Vesey is an associate professor in the School of Criminal Justice at Rutgers University and director of the Corrections and Reentry Project Policy Research Center there. Prior to her employment at Rutgers, Dr. Vesey was a senior research associate at Policy Research Associates in Del Mar, New York. And during that time, she was director of the Women's Program Corps and associate director of the National Gains Center, which was a policy and technical assistance center that provides guidance and support on mental health and substance abuse treatment to institutional and community corrections agencies. Dr. Vesey's research has addressed a number of issues at the intersection of behavioral health and criminal justice, including continuity of care and reentry, police interactions with persons with mental illnesses, mental health and substance abuse treatment in jails and prisons, diversion and treatment services for youth with behavioral health problems, and characteristics of justice-involved girls and women. This morning, Dr. Vesey will describe the population at the nexus of public health and public safety, the people who spend most of their time in our communities but who cycle in and out of our local jails, mostly due to underlying untreated health issues. The current landscape of health and safety services for this population is expensive, inefficient, and ineffective, all paid for by local and state tax dollars. None of us can know for sure what the new landscape will look like under health reform, but we hope that it will include greater connectivity between local jails and local community systems of health care that will result in better and less costly public health and public safety. So without further ado, Dr. Bonnie Vesey.
Good morning. Let's see. This is the technical part. There we go. How about that? My job this morning is to set the stage for today's conversation. I want to give you an idea of the scope of the problem, and in doing so, I want to make a very simple argument. First, that by attending to the health of persons in jails, we will improve public health overall and increase public safety. I think this is clearer than just providing the constitutionally required care to improve the health of detainees and inmates in jail. We know that they come into the facilities often at their worst with complex and often severe problems. If we treat these individuals, we have the possibility of impacting and reducing infection rates in the community. Furthermore, by attending to the substance abuse and mental health problems of these individuals, we can reduce the rates of crimes that are related to those illnesses. The second part of this argument is that by focusing largely on prevention and early intervention and a continuity of care from the community into the jail, we can reduce costs and taxpayer burden, even in this emerging landscape of health care reform with an anticipation of a huge influx of new individuals. Right now, we're participating in a shell game of costs. The public doesn't believe that we are really paying for health care for poor people, but in fact, we either pay through state and federal dollars, even for indigent care in federally qualified health centers or other indigent care facilities, or through Medicaid or Medicare, or we pay for them through county dollars in a sheriff's budget. When we fail to provide early prevention and early intervention care, the individuals end up seeking much more costly emergency care and urgent care when illnesses are at their most severe. I want to be clear that we're talking about a very specific population. We're talking about jail detainees and inmates and not prisoners. Jails are locally administered correctional facilities. They hold individuals who are arrested and held pre-trial, pre-sentencing, and they also hold short-term sentenced inmates, mostly misdemeanors. Jails are, as was said a little bit earlier, community organizations. They're embedded in communities, and they sit as one agency in an array of agencies in a community. Prisons, on the other hand, are state-operated. They hold sentenced individuals, felons, and they tend to be total communities. They're large organizations. They have lots of resources, and they provide care that is similar to what would be available to people in the community at large. Prisons, as such, treat everything from acute through chronic illness. They have capacities to provide specialized housing and so forth. Jails, on the other hand, are best characterized as people processing institutions. Currently, we have about 800,000 individuals held in jails today. But that doesn't capture the magnitude of what jails do. Jails actually book over 13 million people through the facilities every year, and that is a net 9 million separate individuals. These people stay for a very brief period of time, sometimes hours to days. Over 60% of the population churns every week. And even for a jail sentenced inmate, the average stay is 90 days. Most importantly, only a small minority of these individuals will go on to a prison term, about 4%. This means that nearly everyone will return to their communities, and relatively quickly. Some of you who track the criminal justice statistics may have noted that we have a general decline in the crime rate, barring the last year or so, but an increased growth in the jail population. I think it's important to note that this does not reflect a growth in a more dangerous population, but rather it reflects an increase of people held pre-trial, people who cannot make bail, and an increase in people who are returned to custody for probation and parole violations. So related to this, I think, is this the concept of the importance of poverty. Poverty really is at the center of the intersection between health and crime. We know that poor people are more likely to be arrested. We know that poor people are more likely to have health problems. We also know that poor people are less likely to have received treatment for those health problems. We know that jail detainees and inmates are largely young. 40% of arrestees are under 24 years of age. Most are poor. They have very few skills, educational or employment skills. They're largely people of color, and they're largely men. This issue of the intersection of urban poor and the characteristics, excuse me, let me step back. This issue of urban poor is an important issue in terms of who stays in jail and who is released. Because of the inability to make bail, many individuals remain in jail pre-trial when they really do present no greater risk to the community than those who actually have the ability to make their bail. Relatedly, few jail detainees and inmates have any health insurance. either public or private. About 10% have some insurance upon arrest. We also know that they have poor access to care in the community. Even with serious chronic medical conditions, very few people receive routine treatment. A majority use emergency rooms as their provider of choice. That means they're coming in with much more severe problems, and their health literacy is poor. In many cases, they don't know they have an illness. They don't understand how to take care of their illness when they do know about it, and they don't advocate well on their own behalf. Some of these things are likely to change in this new landscape. But because of lack of affordable treatment in the community, it's not unknown that individuals will commit petty crimes or surrender on warrants to receive treatment because they have no other way to receive care. We also know that police will arrest individuals on petty crimes because they know that in jail, at least they will receive some minimal care for their problems, whether it's medical or behavioral health. And we know that judges are more likely now to sentence individuals to jail because treatment resources exist in the facility where they don't exist in the community for these same individuals. I think we have a problem right now in this country where people seek health care, basic health care, in a facility because we as a community haven't found a way to provide care in the community. In terms of health status, chronic disease, 53% of men and 35% of women report chronic medical problems. Their most common complaints are arthritis, hypertension, asthma, and heart disease. In terms of infectious diseases, including hepatitis, tuberculosis, HIV, and other STDs, we know that many of those are generally low base rate illnesses. But the jail population represents a large proportion of those who have these disorders. In fact, somewhere between 12 and 35%, depending on the disorder, of the general population with that particular communicable disease have spent time in jail. Most of the people who have these very serious infectious diseases have spent time in jail. That means jails become a very, very important public health outpost. In terms of mental illness, 63% of men and 75% of women report symptoms of mental problems. In terms of true diagnosis, going through a diagnostic screen, 9% of men and 19% of women meet the criteria for symptoms of a serious mental illness, schizophrenia, bipolar disorder, or major depression, that is actually in an acute phase, with an additional 50% who would meet the criteria for other disorders. In terms of substance abuse, 85% of individuals in jails are substance involved. 85%. It's nearly everybody. 2/3 test positive for drugs upon arrest. And we know that drugs and alcohol are a serious component in the crimes committed in the community. These numbers alone are astounding. To think that really our jails are housing people with a large proportion of people with serious medical and behavioral health problems. And it has to be stated that these are not criminal problems. These are clinical problems. Medical and behavioral health problems are clinical problems, and we need to find a way as a society to treat individuals earlier to reduce the likelihood that they will be arrested and placed in jail. Now, in terms of cost shifting, over the past 40 years, we have seen a lot of changes that have had an impact on the health care and the behavioral health care that people receive in the community. In the 60s, we had beginnings of the deinstitutionalization movement. The Rockefeller laws and other drug laws have had a huge impact on arrests and incarcerations, and a long-term impact on poverty in terms of the restrictions we place on people with drug convictions on public supports. We've had restrictions in Medicaid eligibility, and even the expansions of HMOs and carve-outs have in some ways decreased access to the very poor in our communities. The net result is that more people are without health care resources, and there are fewer resources in the community. So ultimately, the reductions in these federally funded, or publicly funded services and health care benefits have saved federal and state dollars. But untreated persons end up in jail, and taxpayers still foot the bill through their county sheriff's budgets. How am I doing on time there? Is Mike, you keeping time for me? I have 15 more. That's excellent. Okay. So right now we have a little under 3,000 jails. The jails vary in size from a few cells in small rural counties to over 22,000 in Los Angeles County. Obviously, their budgets vary and their resources vary depending on the size of the jail. Just to give you a sense of how important the small jails are, however, there are 171 jails right now that have a capacity of 1,000 people or more. They hold 42% of the jail population nationwide, so about half. Big jails have almost a large proportion of the jail detainees and inmates. But about 1,200 jails nationwide, 1,200, almost half, are considered very small jails. That is, they have a rated capacity of 50 or fewer. In large jails actually end up looking a lot more like prisons than they do like other types of jails. They have a comprehensive array of services. They may have an inpatient capacity in a surgical unit. They may have specialized housing for people with acute and chronic mental health conditions. They may have therapeutic communities. Small jails, on the other hand, have virtually nothing. They have custodial staff and virtually no other resource. So in terms of, excuse me, common strategies of health care provision, the very large jails typically have total control over their health care and behavioral health care provision. That means they actually are the employer of the staff. They have a full array of services, including pharmaceutical and lab services. The very smallest jails rely almost exclusively on the community. So they may contract with individual physicians or psychiatrists to provide, or nurse practitioners to come into the jail to meet a need, but they're just as likely to take that individual out of the jail to the community provider. Large jails, while they may have discharge planning, don't have the intimacy with the local agencies to create as easily the reentry and continuity of care. Small jails don't have the time to do discharge planning. On the other hand, because of their relationships with community providers, the people who provide care for these individuals in jail are the same people who provide care for individuals out of jail. This is an important concept when you think about almost half of the jails in the nation fit into that latter model. The middle jails are where a lot of the cost burden happens. These are jails that are not large enough to be able to employ a full array of providers and staff, but they're not small enough to use the mechanisms that small jails can. The typical strategy that these medium-sized jails use is to contract with large for-profit correctional health care companies. There's a big upside to this, and that is they have an idea about what the annual cost will be, although it's known that there are cost overruns, but they do in general know what their costs will be. The downside of this is that there are disincentives for the providers to provide comprehensive and the most up-to-date care to the individuals in their care. As you heard earlier, there is another option for medium-sized, even to large jails, and that is importing a community health model, public health model, into the jail. As was described about in Hampden County Correctional Center, these are facilities, and this is now, Cochs is working with a number of jurisdictions to help them create these models where community-based providers work with the jail to provide services in the jail. This obviously has some significant upsides to it in the sense of continuity of care. There's no information barriers, information sharing barriers. The people who provide services prior to arrest are the same people who provide services during arrest and are the same people who provide services post-discharge. I will just make a couple of brief comments on cost control strategies that jails use, but in general, I'm not going to spend much time on this. Cost control, one of the biggest cost control strategies, in fact, is this contracting for medical and behavioral health services. For smaller jails, we know that a single event, an injury, a surgery, can take up to a large proportion of a jail's health care budget. Right now, jails spend about 15% of their budget on health care costs alone, and that's excluding mental health care and hospitalizations. But for a small jail that has a small operating budget, a single procedure that costs $175,000 to $200,000 can cripple the health care budget for the remainder of the inmate population. In these cases, jails are seeking other ways of being able to protect themselves, either through creating small health care pools plans that are similar to small business health care plans. States are working with, states are passing legislation that will reduce the reimbursement rate that jails provide to hospitals and outside care providers. Right now, many agencies that provide health care to individuals who are incarcerated outside of the jail get reimbursed at 65 to 75% more than the Medicaid reimbursement rate. So in fact, this, by passing legislation, states and legislators are trying to hold these providers accountable and give them the same rate that they would receive if they were to provide care to that same individual if he or she was not incarcerated, so at the Medicaid reimbursement rate. Right now, our current system for people who are arrested goes from individuals with no coverage who use expensive care to post-arrest in jail where individuals receive full coverage for their medical and psychiatric needs. And then they're released back without coverage. The question now really is not how we can better fund jail services. That's really not the question. The question is, how can we create a seamless system between community health care and jail health care so that the individuals who are held in custody do experience a comprehensive and seamless system of care and reap the benefits of this prevention and early intervention. For the rest of the day, we'll be exploring the implications of health care reform on access to care for jail detainees and inmates. After our keynote, we will begin with pretrial detainees and health care reform. Does status impact access to care? Patricia Blair will be our speaker from the American Bar Association. This discussion focuses on whether and how coverage will apply to pretrial detainees versus sentenced detainees, sentenced inmates, community corrections populations, and probation and parole violators returned to custody, and individuals who are enrolled prior to arrest. The second the second paper is the Criminal Justice System and Medicaid, Collaboration or Collision Post-Health Care Reform. Allison Hamlin will be presenting that from the Center for Health Care Strategies. Currently, jail health care and Medicaid are virtually exclusive categories. You either receive one or you receive the other. The questions for the future are how can jails and community-based health care create win-win scenarios that contain costs and increase continuity of care? Finally, can health reform reduce spending and lower recidivism for our nation's jails? And Pam Rodriguez will be presenting that from Task, Illinois. And this is really a comprehensive discussion of the possible implications of health care reform on jails. And many of the ideas are a call to action. I think we have a long day ahead of us. I think it will be extremely interesting and I hope very productive. And I will stop with about 8 minutes to spare. And open this up for questions.
Good morning. Thank you very much for the presentation. I'd be curious on your thoughts on defining what you believe healthcare reform is from your perspective.
Oh, gosh, this is, I will say that I could defer this to my colleagues, and you'll hear a lot about the implications, I think. From my perspective, really what we're talking about is covering a class of individuals based solely on income that were never covered in the past, and that is single childless adults. These are the same folks who have no care in the community right now, and they're the ones in our jails who sometimes have the most serious and complicated issues. So, I mean, I think that's one of the biggest issues. The second issue is if we get parity of mental health and substance abuse services with medical services, primary care services, the possible impact of being able to get more people into recovery earlier on will be tremendous, both in terms of reducing rates of infections that are substance use related, reducing arrests that are related to untreated mental illness or untreated substance use. People will be entering jails in better health if we can take care of people on the outside before they hit the front door. Even if they are arrested, they will be hitting the doors in a better health status.
Hi, I'm Don Murray with the National Association of Counties. The Pretrial Justice Institute has come up with a new term, pre-entry.
There you go. I like it.
And so my question is, could you see, before someone goes to jail, in a neutral assessment center, it would have to be secure, where you could divert people before they go to jail? And the advantage of this would be you would avoid the stigmatization of jail.
Right.
You know, a mentally ill person going to jail, the difficulty might be placing them now into a health unit when they've been stigmatized by being in jail. What would you think of a sort of pre-jail assessment center?
Well, I think there are examples in the juvenile side that are very similar to that, where there are assessments and attempts of diversion, pre-trial diversion. And I think it's a great idea. I think we need to think about those things, particularly if we're incarcerating people because of illness. That just doesn't make any sense to me. We need to be able to screen, identify, and get people into treatment rather than incarcerating them because they have no access on the outside. Yeah. That's it? Okay. I'm done, apparently. Thank you so much for listening.